Good morning and good afternoon, and welcome to this 60-minute online event about embedding capacity development in global health research. Thank you for joining us today. My name is Joanna Schellenberg. I'm from the London School of Hygiene and Tropical Medicine, and I'm co-hosting this event together with Peter Steinmann. We hope to inspire you to consider embedding capacity development in global health research. We will be sharing with you two case studies illustrating diverse approaches to a common theme. PhDs registered at African universities. Over to you, Peter, to give us an overview of what's coming up.
Good morning and good afternoon. I am Peter Steinmann from the Swiss Tropical and Public Health Institute. Welcome to all. We have a packed agenda today. First, a few words of welcome from Professor Antoine Flahaut, co-president of the Geneva Health Forum and director of the Institute of Global Health at the Faculty of Medicine, University of Geneva.
Good afternoon, good morning, everyone, and it's a warm welcome on behalf of the Geneva Health Forum. You know, the Geneva Health Forum is a joint initiative initiated from Geneva, but which gather a lot of academic institutions, but also NGOs, international organizations, and of course, the London School of Hygiene and Tropical Medicine and the Swiss TPH, which are almost co-founders of this initiative. Your group is very productive, has published a commentary in the BMG already. Your group is united by your burning interest in embedding capacity development in global health research, and we are very proud of that. And it's for us the fruits, the wonderful fruits you can give with convening in spite of this pandemic today. Thank you very much for giving me this opportunity to say you hello, and also good luck for these fruitful discussions this afternoon.
Thank you very much, Antoine. We will start with short presentations on case studies from projects focusing on Ethiopia and the Central African region, then hear from 5 PhD students associated with these projects, and then move to our panel discussion. The language of the session will be English, but for those more comfortable with French, questions in French are welcome. La langue de la session sera l'anglais, mais pour les francophones, selon vos préférences, prière de poser vos questions en français. And we really want to hear from you. Please post your questions for presenters, for PhD students, and for our panelists in the question and answer box on your screen. During the session, you will be able to upvote questions you see in the box, and we will prioritize those with the most votes.
First up, we have 2 5-minute presentations from Ethiopia, sharing experiences of embedding capacity development in a child health research study. Dr. Della Berhanu will give you an overview of the child health research study itself. Then Professor Lars Schocker Persson will talk briefly about the 9 embedded PhDs. Over to Della.
My name is Della Berhanu, and I'll be presenting on the DAGU project, which evaluated the Optimizing Health Extension Program in Ethiopia as one of its components. A little bit of background on child health in Ethiopia. The country had made massive progress over the last 2 decades, decreasing under 5 mortality. However, despite these successes, there is still low service utilization for under 5 children. The graph on the right side, for example, shows among under 5 children with symptoms of pneumonia, the 2016 Demographic and Health Survey showed that only 30% had sought care from an appropriate health provider. So the solution for this was a national strategy for demand creation, which was known as Optimization of the Health Extension Program, or OHEP, which was led by the Ministry of Health and implemented with support from UNICEF, Save the Children, PATH, Last 10 Kilometers, and was funded by the Bill and Melinda Gates Foundation. So taking a deeper look at the OHEP program, the goal was to improve newborn and child health outcomes. This was done by aiming to increase integrated community case management of childhood illnesses and community-based newborn care service utilization. And this had three specific components or areas of intervention, each of them having multiple components. The first one was community education and mobilization. The second one was capacity building of health workers or health extension workers in this case. And the third one was ensuring program ownership and accountability at the district level for childhood health services. So in terms of implementation, OHEP was implemented in 26 districts over the course of 2.5 years from 2016 to 2018. The evaluation was done by the Dagu Collaborative, which included the London School of Hygiene and Tropical Medicine, the Ethiopian Public Health Institute, and 4 local Ethiopian universities. So the evaluation assessed the effectiveness of OHEP intervention in increasing care seeking for sick under 5 children. It had a baseline and endline surveys in 26 intervention and 26 comparison districts, and included around 6,000 households at baseline and twice as many at endline, around 300 health extension workers, and around 150 health posts, which were the primary level care providers. So if you look at the distribution of intervention and comparison districts, they're in the 4 largest regions of Ethiopia, and what you see in blue are comparison and yellow are intervention districts. So just to share a few key findings, and you can find the detailed evaluation results, which was published in BMJ Open last year. So our primary outcome was care seeking for 2 to 59 months old sick children for an illness in the 2 weeks prior to the survey. And what you have here in dark blue are intervention districts and gray are comparison districts. So at baseline in intervention districts, 58% of ill children sought care from an appropriate provider. At endline, it dropped to 37%. In comparison areas, it was half had sought care, and endline, it had dropped to 36%. The difference in difference analysis showed that there was a decrease in 8 percentage points, and the p-value was 0.21. We also looked at treatment. So ORS treatment for children 2 to 59 months of age with diarrhea in the 2 weeks prior to the survey. So in intervention areas, 53% of children with diarrhea had received ORS, and an endline was similar at 50. In comparison areas, it was 40% at baseline who received ORS, and endline was 53%. The difference in difference analysis showed a decrease in 16 percentage points, and the p-value is 0.41. We also wanted to see if the findings from the household level were similar to that from the health facility level. So we looked at registers assessing care utilization for ill children 2 to 59 months of age in the last 3 months. So what we found here was in intervention areas, a baseline on average of 15, 2 to 59 months old children were seen. At endline, the average was 21. In comparison areas, it was 14. And at endline, on average, 12 were seen in the 3 months prior to the survey. The DID was 8, and the p-value was 0.41. So to summarize, there was no evidence of an effect of OHEP on care seeking. Similarly, a process evaluation showed that the majority of the interventions were delayed and implemented with low fidelity. And lastly, we can summarize that perhaps complex interventions with multiple components need longer implementation time to show an effect. Thank you very much.
Thank you so much, Stadella. A quick reminder to all attendees, you can post questions in the question and answer box on your screen. Now, over to Professor Lars Persson, who will talk briefly about the 9 embedded PhDs. Thank you.
My name is Lars Persson. I'm professor in public health evaluation at London School of Hygiene and Tropical Medicine, and I've been based at the Ethiopian Public Health Institute together with a team from London School. Let me tell a bit about experiences of embedded research capacity development nested into a child health evaluation project in Ethiopia. 4 Ethiopian universities and the Ethiopian Public Health Institute collaborated with London School in this evaluation. 9 PhD candidates were recruited and registered at these 4 universities. Supervision was done by researchers from the universities and co-supervision from London School colleagues based in Ethiopia. The PhD candidate topics contributed to the overall evaluation. They were engaged in the evaluation fieldwork and had some individual sub-studies, usually with qualitative approaches. Here you see some of their PhD topics. A few studied illness themes, such as suspected pneumonia and neonatal conditions. Others studied quality of care in primary health care. Some approached equity, geographic distributions, and social equity in prevention and use of healthcare services. One studied the role of voluntary women's development group for maternal and child health. The PhD students are in a scientific harvesting period just now, and here you see some examples of recent publications. They write theses that are paper-based with a summary or synthesis of the 3-4 papers they have published in international peer-reviewed journals. 3 of the candidates will defend their PhD within the next month. Embedding PhD studies within a large evaluation project increases the relevance of the topics. Project partners working together in supervision and joint workshops, that has increased opportunities to learn from experts in different fields. Both the PhD students and supervisors from all involved institutions have benefited from this opportunity of mutual capacity building. Thank you.
Thank you very much, Lars. Next, we have 2 presentations from our second case study in the Central African region. The first presentation is in French with slides and subtitles in English. Dr. Bonaventure Savadogo will give an overview of the program, and then we will hear from Professor Ayola Akim Adegnika, who will introduce the perspective of PhD supervisors.
Mes salutations chaleureuses, mesdames et messieurs. Je suis Dr Bonaventure Savadogo. J'ai le plaisir de vous présenter le projet de lutte contre les maladies tropicales négligées en Afrique centrale, suivant le plan que vous avez sous les yeux en 5 points. Le cadre institutionnel et l'organisation du projet. Les institutions suivantes portent le projet. La communauté économique et monétaire de l'Afrique centrale, composée par les 6 pays que vous voyez présentés sur la carte, qui correspond à la zone d'intervention du projet. Cette zone d'intervention a une population d'environ 52 millions et couvre une superficie d'environ 3 millions de kilomètres carrés. L'OCEAC a été chargé en tant qu'agence de mise en œuvre de la santé de la CEMAC de mettre en œuvre ce projet. Le Suisse TPH a été choisi comme consultant pour appuyer l'OCEAC dans la mise en œuvre de ce projet-là. Toujours sur le plan de l'organisation, le projet est logé à l'intérieur de l'OCEAC sous forme de coordination régionale avec un chef d'équipe et du personnel Suisse TPH comme OCEAC. Le chef de projet est basé à Bâle avec un pool d'experts qui interviennent à besoin. Les objectifs, il y en a principalement deux. De supporter les interventions de contrôle et d'élimination des MTN et de supporter les recherches sur les NTD par l'octroi de bourses qui aboutissent à l'obtention d'un doctorat. D'un point de vue approche conceptuelle, l'idée de base repose sur ce qui est marqué en rouge, le renforcement mutuel entre les interventions et la recherche. Comme vous le voyez sur le schéma, le volet 1, intervention, le volet 2, et recherche, et qui font des échanges pour se renforcer mutuellement. Le processus de mise en œuvre. Nous avons commencé par la phase de démarrage, mise en place de l'équipe, des comités, des manuels, puis une phase de préparation et de sélection des projets d'intervention et des projets de recherche pour les étudiants. L'élaboration donc des appels à candidature, une tournée dans tous les pays de la CEMAC pour rencontrer les cibles, les chefs de programme NTD dans le ministère de la Santé, les universités, les écoles doctorales, les centres qui peuvent accueillir potentiellement des doctorants pour expliquer les conditions de participation à cet appel à candidature-là. Après donc les applications, le comité d'experts s'est réuni et a procédé au choix des projets d'intervention et des projets de recherche. Puis l'OCEAC a validé par une rencontre ce choix-là. Nous en sommes où aujourd'hui? Pour le volet 1, nous avons 9 projets qui sont mis en œuvre dans les pays. Malheureusement, en 2019, le Covid est passé par là, a eu un impact négatif en termes de mise en œuvre, mais les programmes sont en train donc de se réadapter. Le volet 2, on a 19 doctorants qui sont en train donc de mener leur thèse, 8 femmes et 11 hommes. Leurs travaux ont été impactés par le Covid, mais sont en train de se réadapter. 2 ont déjà publié des articles dans des journaux scientifiques. Et le projet a pu tenir sa conférence annuelle par vidéoconférence. Je vous remercie pour votre attention.
Merci beaucoup, Bonaventure. Please, those who listen, do write your questions or comments in the Q&A box, and we will do our best to respond. Now, Professor Ayola Akim Adegnika will speak from the perspective of PhD supervisors.
Good afternoon, ladies and gentlemen. I'm Ayola Akim Adegnika, professor from University of Tübingen and director of Centre de Recherche Médicale de Lambaréné in Gabon. I would like to present you today the perspective of an NTD PhD supervision at the KFV OCEAC project. As you know, Africa is endemic for most neglected tropical diseases. All regions are concerned and many efforts are put in place to control these infections. The Central African region, which is mostly affected, lags behind other parts of Africa in progress toward meeting the NTD control and elimination targets. These difficulties, including a number of challenges, including finance, qualified human resources, appropriate strategies, availability of evidence-based data for better policy making. Le cadre de OSIAC project, lutte contre les maladies tropicales négligées, consists of support intervention to control or eliminate entities at the national program level, but to build local entity research capacity through PhD student fellowship. This fellowship is offered to PhD project which is in alignment with a national strategic plan. Also, the fellowship is expected that at the end of this project, a research project should be able to support innovation and innovative at local or regional entities control. The main findings from this program should enhance local entity control and generate researchers who are embedded in the regional public health community. The training of PhD students at the local university have some advantage. Definitely, these students will be registered easily at the local university. They will have easy access to the sample to be collected, easy community and the stakeholder engagement, timeline completion of the sample collection, and thesis report. At the end of the day, the cost of this kind of PhD will be rather cheaper compared to the external PhD for which travel or living costs are occurring. Some challenge also is happen on this local project, particularly in this region where everybody is in this region which is francophone. Corporate English proficiency improvement are recorded where students are less exposed to other students from other regions of the world where English is mostly spoken. There's a limitation opportunity to this student who doesn't speak English and may not be able to face the call later. Another big challenge for this program is the COVID-19 pandemic. This COVID-19 pandemic affected drastically this program through the curfews which reduce drastically field work activities, lockdown which delay all procurement, and the active involvement of PhD students in COVID-19 management under the decision of the government which request all students, all PhD or postdoc or biologists to engage themselves in the national action. Importantly, also, if this program is only focused on the local PhD, we may not always have the best student to be chosen, and therefore we will stick with what we are on the hand. Here is some activities of PhDs which are under my supervision. Here is the fieldwork activity of arboviruses activity in Gabon, as well as the bemidazole resistance trial, in which is conducted in the area where people are really affected by the helmets. At the Guinea Equatorial region, in this slide, I can show you the community engagement activity in the left side and the lab activity in the right side of our student, which is the only one we have at the Guinea Equatorial region. For perspective of this project, it's very important that we need to have more implication of the local authorities through engagement, more collaboration with the host institution, and the contracting the grant agreement with the host institution rather with students, to allocating 4 years minimum to allow field preparation to pursue the program at the Central African region, and also to extend the program to other regions of Africa. Ladies and gentlemen, having said this, I would like to thank you for your attention.
Thank you so much to Ayola Akim. Thank you, Akim. Now, we have the chance to hear from 5 of the PhD students enrolled through our 2 case studies. I want to draw your attention, please. If you have questions and comments, please could you put them in the Q&A? I can see a number of people have been asking in the chat box whether the recording of this session will be made available. Yes, indeed, we will find a way to make it available to you. The session is being recorded and it will be made available to you as attendees. But please, any other questions or comments, do post them in the Q&A box and take a look in that Q&A box, because you can upvote and prioritize which questions we answer when we come to that part of the session. Thank you. So over now to hear from the 5 of the PhD students who are enrolled through our 2 case studies.
My name is Atkure Defar. I work for the Ethiopian Public Health Institute. I am a DAGU PhD student registered at the University of Gondar in Ethiopia. In overall, my PhD topic focuses on understanding of the geographic perspective of child healthcare utilization for common childhood illness such as diarrhea, malaria, and suspected pneumonia in Ethiopia.
Hello everyone, I'm Deros Ketachao and I am one of the PhD students at the DAGU project. I am studying my PhD on quality of care for common childhood illnesses within the integrated community case management in Ethiopia.
Je suis monsieur Joseph Axel Ngati. Je suis inscrit au niveau de l'université Marien Ngouabi de la République du Congo, plus précisément au niveau de la faculté des sciences de la santé.
Hello, my name is Alam. I'm a PhD student at Mekelle University, Ethiopia. My research project is on equity in maternal, neonatal and child health services utilization.
Mon travail de thèse porte sur le poids des maladies tropicales négligées et donc il consistera à regarder au niveau des zones rurales de 4 départements précisément du Congo, combien d'individus souffrent des MTN, combien d'individus arrivent à mourir de certaines des MTN. C'est vrai que toutes ne tuent pas, mais certaines d'entre elles peuvent tuer.
Hi, my name is Haptam Bayena. I'm an Ethiopian by citizen. I have been working in the Southern Nations, Nationalities and Peoples Regional Health Bureau here in Ethiopia. PhD research topic is on health system research, particularly on childhood referral care. I'm dealing with on healthcare referral practice and its challenges for common childhood illnesses in the primary healthcare units of 4 regions of Ethiopia.
Je suis Lisbeth Mavungo, inscrite à l'université Marien Ngouabi, plus précisément à la faculté de sciences et techniques, en sciences biologiques. Donc, mon sujet de thèse est intitulé Biogéographie des serpents venimeux et épidémiologie des morsures de serpents en République du Congo.
I choose to do my PhD through DAGU project because the DAGU project is a capacity building program run by the involvement of a senior professor from one of the world-renowned university, that is London School of Hygiene and Tropical Medicine, and the 4 Ethiopian universities, namely Geneva University, Mekelle University, Hawassa University, and the University of Gondar.
Doing my PhD at Hawassa University while embedded within the DAGU project has a unique additional advantage in that my research work has been supervised and supported by experienced researchers from my university as well as from the central office of the DAGU project.
Nous avons choisi de faire notre PhD dans le programme de maladies tropicales négligées parce que nous nous sommes rendus compte que finalement les morsures de serpents sont un réel problème de santé publique. Et au niveau national, il y a vraiment un réel problème en ce qui concerne les données épidémiologiques, mais aussi de prise en charge des cas de victimes de morsures de serpents.
Ce projet, je l'ai très vite accepté parce que d'abord, je suis africain, j'appartiens à l'Afrique centrale, que gère l'OCEAC. Et en plus, nous formons une cohorte de plusieurs pays. Et donc, c'est un diplôme qui est bien valorisé parce que ça montre des pays unis tout ensemble. Et en plus, je dois l'avouer que quand on vous présente un projet avec une bourse doctorale, ça motive encore plus de faire le travail.
Doing a PhD under DAGU project is unique because the focus of DAGU project is implementation science, that I like most. And it's very relevant for the current evidence-based decision making.
The knowledge and the skill I found on implementation science research, along with the different courseworks and advanced research methodologies are the most valuable part of my PhD study so far.
Moreover, I have got an opportunity to share the research findings at national and international conferences.
La particularité, c'est déjà le fait d'avoir obtenu la bourse qui nous permet de mener nos travaux à bon escient et aussi de permettre à ce que nous puissions donner des informations au niveau local et au niveau national.
As a PhD student, identifying a research agenda and the discussions I had with my professors were the most valuable part of my study.
Ce qui est unique, c'est que déjà nous sommes suivis par un organisme, donc l'OCEAC, qui est bien expérimenté et est assis en Afrique centrale depuis bon nombre d'années. Et donc ça ne peut que donner de la confiance pour la réalisation du travail. C'est ça que je trouve unique de ma part.
Dans ce programme, depuis que nous avons commencé, non seulement que nous avons eu déjà participé à une université d'été, pendant laquelle nous avons essayé d'améliorer nos connaissances sur certaines informations, certaines matières que nous ne maîtrisions pas au départ. Et en ce qui concerne le terrain, il y a des espèces nouvelles que nous sommes en train de découvrir et tout cela fait partie de ce qui est valeureux pour nous.
In addition, DAGU brings the academia, program people, and developing partner all together for evidence-based program implementations for better health outcome of the community. That I believe this approach is ideal in solving the health system challenges we have.
It's wonderful to see and hear the PhD students we are talking about in these videos. Thank you all for your contributions. The rest of the session is now devoted to our panel discussion. Our four panelists are Susna Dey from the Bill and Melinda Gates Foundation, Professor Margaret Japong from the University of Health and Allied Sciences in Ho, Ghana, Dr. Marta Tufed from the UK Collaborative on Development Research, and Dr. John Amwasi from the Kwame Nkrumah University of Science and Technology in Kumasi in Ghana. We start this with a couple of questions for each of the panelists in turn before we open up and bring in questions from our attendees posted in the Q&A box. Now, I would like to start with Susna. You are with the Bill and Melinda Gates Foundation and serving as the Deputy Director, Health and Nutrition for Ethiopia. Could you tell us a little bit about how the foundation is engaging with capacity development in global health research and development work?
Thank you, Peter. And I just first want to thank you and the team for an opportunity to speak on such a critical topic. It's a very important one for the Gates Foundation. And I was really warmed to see the DAGU work featured today, as well as to hear the testimonials from the students themselves. In response to your question about the foundation's engagement in capacity development, I think I want to first acknowledge the BMJ commentary that has inspired this panel session today, that the research capacity gap between the global south and the global north is wide and is closing too slowly. And this indeed has been a concern of many BMGF colleagues over the years, and they've tried to address this, including Dr. Paulin Basinga, who helped inspire some of the DAGU work today that's been featured. And there's been a number of capacity strengthening embedded health research grants that we have supported over the years. And I'll just name a few. There's been similar nested design approaches to those featured today in Pakistan, Uganda, and Mozambique, where master's and PhD students, as well as their universities and supervisors, were supported to address some of the critical research questions that were nested in the program design themselves, targeting ICCM and MNCH. In addition, beyond a nested approach, in Ethiopia, for example, we are supporting a number of institutional strengthening capacity grants that target local universities, research advisory councils, public health institutes, trying to support the contribution of the health evidence in Ethiopia, the domestic capacity to translate evidence to action, and then also strengthening local data analytics capacity. At a regional level within the sub-Saharan African continent, we are supporting regional networks and institutions such as the African Academy of Sciences. So I could go on, but in the interest of time, I think what's particularly exciting now is that this issue of narrowing the research capacity gap is perhaps even more of an institution-wide priority given that we have a new diversity, equity, and inclusion strategy. It's just been posted on our website in the past week, and it seeks to reinforce the Foundation's core tenet of equity. And one of those, the strategy's pillars is on partnerships and voice. And through this pillar in particular, we want to be much more deliberate and intentional about diversity and equity considerations when designing and implementing grants. Now, to inform how we actually roll out this strategy, we're in the process both at the Africa level as well as at the country level to take stock about what have we learned with our past efforts. Where are the gaps? Where are the issues that still need to be addressed? And in doing so, we hope that we can develop a much more concerted direction about how we program in the space and how we support this really critical issue.
That's all very interesting. Thank you for sharing this. And what are you hoping to learn as part of this stock-taking exercise?
Yeah, there's a couple of key questions. And I think at a continental level, led by my colleague, Dr. Nosa Orabaton, there are a number of emerging questions. One is, how can we start to support more concertedly capacity strengthening with the researcher at the center, but thinking about the research institution dyad or the researcher university dyad. So how can we start to think about strengthening both the individual as well as the institution and the broader research ecosystem? In addition, as we support research capacity on the continent, how do we preserve the leadership voice and ownership of African researchers as well as policymakers? Within the Ethiopian space, we want to understand, what do we mean by local institution strengthening, inclusive of individual strengthening? Strengthen how and to what end? What metrics should we be using to know that progress is being made in this space? How do we better support that research to policy action continuum? How can we make sure that we're supporting questions that policymakers are interested in? I think essentially, how do we better prioritize local problems, local questions, local contexts when supporting research through our grants? So it's a tall order of questions, but this is essentially what we're hoping to learn. So we'll see how far we get, hopefully quite far.
Thank you so much, Sushna. That is absolutely brilliant to open our panel discussion. I'd like to now turn to Margaret. Margaret, you are both Professor and Director of the Institute of Health Research and at the University of Health and Allied Sciences in Ho in Ghana. Could you share your thoughts about what global health research actually is, and where do you see the gaps?
Thank you very much, Joanna, for the opportunity. And let me say, those were two very interesting case studies with embedded PhDs that were presented earlier. And I was particularly happy that the projects were aligned to national strategic plans, particularly the NTD ones. You asked me an interesting question, my thoughts about what global health actually is. And I've asked myself that question several times. I'm a preceptor on an international global health master's program. And sometimes I ask myself, what's the difference between global health, global public health? And I get a bit confused myself sometimes. But then when you look in the literature, you see that different authors define them differently. I've seen definitions like global health is research for the North conducted in the South. And I've asked myself, what does that mean? And then I've seen other definitions which say global health is public health done somewhere else in a place you do not call home. So then I begin to scratch my head and ask, so what about research for the South conducted in the North? Does something like that ever exist? Do we have researchers moving from Africa, going to the North to say they have funding to do research on cardiovascular diseases? I'm yet to hear about that. But for me, what it is called is not what matters, but what is done to address a particular health problem and the various partners that come together to address that problem. In Ghana, at the end of the day, the mother in the village just wants her child to live, and the nomenclature doesn't matter. She knows that her child is sick, somebody has come there to help her make sure that her child is well. Now, in the last 2 decades, several scientists from the North have had their capacity built in the South because of global health partnerships. And they have actually returned to a system that allows them to thrive. And I talk about the academic environment or the research environment that puts systems in place to allow them to move from where they started off as PhD students to wherever they want to reach. And sometimes you've had these students that you have trained in Africa come back as experts on African issues. But then you also have African scientists who train in the North as part of these global health partnerships. They learn a lot, they build a lot of skills, but they don't want to come home because the systems and tools are not available to support them. So I'm happy to see the way your African scientists were embedded in those case studies because they were trained in African institutions with the necessary support. I don't know what the long-term plan is, but I see this capacity building process activity, not as one activity, but as an entire process. So whatever we call it, there's a health problem that needs to be addressed. But we should note that these public health problems are characterized by very complex interactions between disease dynamics and societies. So really, it's not just the technical and theoretical knowledge which matters, but a knowledge of the context within which the problem exists. And that's why I was quite happy that the PhD studies were embedded within the strategic plans of the countries. And that is very critical because you hear people talk about projects that are outside the remit of what happens in the countries. So I think there's the need to have program implementers also have their capacity built to work together with researchers and academics to deal with public health problems.
Absolutely. Thank you so much. I don't want to cut you off, but I just want to very quickly ask for your brief comments on how do you see fairer and more equitable partnerships being forged? And in particular, maybe, what do you see the role of African governments and African institutions being? But very briefly, if you could.
Yeah, okay, thank you very much. I think we've all seen the experience of COVID and the challenges, and even more recently, how British government is cutting back on funding to developing countries in areas of NTDs, etc. I think it is important that our African governments get together, put our act together, and support the needed capacity in our countries to ensure that we are able to identify problems that affect us and be able to deal with them appropriately and in a sustainable way. It doesn't mean that the problem is ours and so we can handle it on our own. It requires a lot of partnership and engagement with other people that we can work together and ensure that the problems that we identify are addressed. Otherwise, he who calls the piper will definitely always pay the tune. Thank you.
Thank you very much, Margaret. Turning now to Marta. You're the Executive Director of the UK Collaborative on Development Research, which is central to efforts to coordinate funders. Could you comment first on the importance of coherence and how this can be achieved?
Sure. Thank you so much for the invitation and the opportunity to comment on such an important topic, which is really essential to address many of the challenges that we're facing today. So at UKCDR, we are not funders ourselves, but we bring together the major funders in the UK that are interested in research for international development. So this includes government ministerial departments, research councils, and organizations like Wellcome Trust. In the UK has had a long tradition of outstanding research for and with low and middle income countries, and it has invested significantly over many decades to strengthen capacity and the enabling environment for research to happen. But strengthening capacity really requires a very long-term vision, and this tends to go beyond the usual grant cycles, and the impact is not necessarily that obvious until decades later. So it's not always an easy sell within funding bodies. And so we believe it's very important for funders to be working together in partnership to achieve long-term sustainability. So this is what we do at UKCDR. We do not coordinate. No one likes to be coordinated. We try and ensure coherence across funders. So, for example, we do this primarily in three ways: through analysis, providing funders a better understanding of who's doing what where, working in country as well to understand what the needs are, and helping identify opportunities for collaboration or for complementarity. So where one funder pulls up, for example, then another one can steps in, and so that you have continuity. And so we've been publishing a number of reports on the UK's investments into fellowships in Africa. We mapped over 5,000 fellows across 17 different schemes. We've also mapped 300 capacity strengthening initiatives in health. There's a lot of initiatives there. So how do we sort of join the dots between all of these? The other way that we facilitate coherence is through convening. So we've been convening a research capacity strengthening group of funders for over 10 years. And this brings funders as well as practitioners to share, learn, and improve practice. And then thirdly, the way we achieve coherence is by providing information on best practice. So we are currently leading a cross-government and welcome review of UK-funded research capacity strengthening in low and middle income countries to identify what lessons have been learned today. And we're also very interested in helping funders support equitable partnerships. We've published over the years guiding principles on this, touching on issues of the need around setting agendas jointly, around co-creation, and around recognizing merits of all involved. So we're also doing this in partnership with another international group of funders, the Essence group of funders, which brings together capacity research funders in health, a very interesting group. So in summary, given the volatility of certain sources of funding, as we're experiencing very sadly here in the UK at the moment, it's really important for funders to work together to build on each other's strengths and with a better understanding of local needs to make sure that we achieve a more robust and sustainable impact.
Thank you. This is often still an activity which is from the north to the south. Is there a way how we can shift the center of gravity more towards the low and middle income countries?
Sure. So, I mean, I guess it's probably worth reflecting on what we mean by shifting the center of gravity. I think it's fair to say that traditionally funders in this space have been supporting researchers and PhD students from low and middle income countries at universities in high income countries. And over the years, some funders have started to shift their strategies to support researchers at universities and MICs that we've seen from the examples today. But if we take that even a step further, some funders have gone as far as funding national research councils and regional organizations to develop funding schemes according to locally identified priorities. And it's this type of evolution that we're very keen to support. Some good examples of this, we heard from Susna about the African Academy of Sciences and the ASA program, but there's others like the India DVT Alliance and the Science Granting Council Initiative across Africa. And what these initiatives really have in common is that they take a holistic view. So they aim to strengthen not only at the individual level, but also institutional and national level. And they recognize that strengthening research capacity is most effectively done through high quality science. And so, focus on supporting the development of competitive research leaders through not only investing in individuals, but in the environments that nurture them is really important. So you need to support strong institutional leadership, you need national government support, but you also need the well-researched environment with critical mass, and the critical mass is really important, as well as a strong research culture. And then partners and collaborators that can bring complementary skills, and then that continuity of support over the long term.
Marta, thank you so much. I'm sorry to be cutting you short. I'm mindful that I want to give time to our last panelist, as well as to something from the Q&A box. Our last panelist is Dr. John Amwasi from the Kwame Nkrumah University of Science and Technology and the African Research Network for Neglected Tropical Diseases. First of all, John, just tell us your perspective. How many institutions in Africa run global health programs?
Thanks for that, Joanna, and greetings to everyone. Bonjour à toutes et à tous. It's really a pleasure to be here and thinking about which African countries run global health programs. The truth is, it's very difficult to get a handle on the actual numbers. So the short answer is we do not know, but I can speak specifically to right here in Ghana at my university here at Kwame Nkrumah University of Science and Technology. Our School of Public Health just launched a global health program, which we should be starting enrollment this fall. Again, it is well known that we have some programs in South Africa and some in Nigeria and also in Kenya, of course, and in Tanzania, but not that many. And of course, if you want me to go on, I could comment a little more on why this is the case, largely because of the intrinsic multi and interdisciplinary nature of global health in itself. And Prof. Japon really tickled me with her comment on some of the funny definitions of global health, which actually are a reflection of
Is it me, or have we temporarily lost John?
The fact that you would need disciplinary health-related research, or the institution would need to have access to faculty in another department or in another institution outside of that institution who have the expertise to teach a wide variety of courses. Makes it very difficult for any institution to run a true global health program. And so this is perhaps a major challenge, and I could explain a bit more, but I know there's lack of time, so maybe we could go on to the next question.
Okay, thank you so much. Yes, really good points there. Do you feel, I just want to ask you, do you feel that local universities in Africa respond to local research needs? This corresponds to something in the Q&A box I have seen as well. And, you know, how is that response, local universities, local needs, how might those links be made stronger?
Right, I think that's a great question, Jonah. And for me, the question really is, are the local so-called research needs clearly articulated, and who is articulating these? You know, the prevailing model of global development partnerships, and Margaret did articulate this also, has often been program focused, and the priorities are often set excluding country authorities or country experts, especially academics. So what happens is this ends up severely limiting the close connection between priority setting and actual research. We've seen how, unfortunately, the UK FCDO has withdrawn from funding NTDs. This is a big blow, and for me, a clear example of a failure to really appreciate what the priorities might be. And I can say this pretty directly. So I'd recommend something like establishing a minimum criteria for priority setting engagement, which should by default include country academics and experts. And I want to make specific mention of the RFI, which has been the Research Fairness Initiative, which has been put forward by CORED. I must be very blunt here. I find it very surprising that after years of RFI being put out there and the solid nature of how this was developed, the uptake is rather low, very low. But it's a solid piece of work. Very few funders have taken it up. Very few have even attempted to engage. But for me, it's a reflection more of the lip service rather than the actual willingness to engender change. And we've seen this even with COVID and the access to vaccines and other things, how the lip service is clearly mismatched with their realities on the ground. I don't want to digress, but again, just the importance of the structural inequities, which then make it impossible for these capacity building activities to be fully embedded within the training for global health in the global south.
Thank you very much, John. We are already approaching the end of our session, but we still have time for a couple of questions from the Q&A box. I'm now going to ask the first one, which is the trending question, if you want. And I would like to ask Susna, the question is, what is different between just giving a couple of grants to PhD students, having them do their research in the country, on the continent where they are based, versus really these programs of capacity building?
Yeah, no, and I think that's what we're actually trying to explore as we go forward, is shifting from one-off or individual grants to much more of a concerted program approach. I think we've heard from the other panelists, as well as from the presentations, that it's an ecosystem of partnerships. It's not just about the individual researcher, it's not just even about the individual institution, it's that ecosystem of that research to policy as well that we need to think about within a country and then broader as well within the continent. And so I think in terms of what you've just mentioned, that is definitely a trajectory that we haven't yet achieved within the Gates Foundation, but we are moving in that direction. And that's part of the stock taking exercise that we wanted to do, is so that we can shift from individual grants to thinking much more concertedly about a program of support to address a lot of these underlying issues that you were mentioned. And of course, we can't do it alone. Others need to come along as well. And we should be doing this in partnership with many stakeholders, as has been mentioned.
Thank you very much for your answer. I would like also to ask Margaret the question. The question is on the role of implementation research. What are your thoughts on the impact or the pathways, how implementation research can be embedded versus just basic research, what we talk here in PhD training?
Thank you very much for that. I think if we understand or know really what implementation research is, it is teamwork, bringing together multiple disciplines and partners together to address a real life problem. And because it is embedded within the health systems, you have the program managers, the service providers as part of the research team, because half the time they understand the key issues on the ground. And we researchers also have the skills to be able to address these problems in a scientific way, in a systematic way. So we need to work together and understand each other. And once we are able to embed this approach within our capacity building programs, it makes a lot of difference, and it helps us address real problems that relate to the people in the countries in which we work. Yeah.
Thank you very much. And then we have another question for Marta this time. It seems that PhD students training is important. We all agree on that, but there also needs to be capacity at the institutions where they are based.
Yeah, I think this is a really,
yes.
think this is a very, very important question. So it's not only about training the researchers, but also it's training the environment in which researchers can flourish and the research can have an impact. And that includes the financial systems, it includes the grant making capacity, it includes the contracting capacity. This is something that funders that have shifted at center of gravity are beginning to understand and are starting to put in place programs to support the wider environment. And so this is relating back to the question that someone asked earlier about what's the difference between just funding individual researchers versus in a program. This is what this allows to do. One really important initiative that has come up in the past few decades is the past decade, not few decades, is the Good Financial Grants Practice, the GFGP. And this is a mechanism by which research institutions across the world, not only in the South, can self-assess in terms of their financial capacity and can therefore put in place plans to address those challenges, and funders can also understand what those challenges are.
Thank you very much, Marta. We are about to draw to a close. I'm going to try the impossible, ask each of our four panelists for their closing comments in 10 seconds each. Over to Sushna first.
Yeah, very hard to do. Lots I've learned. I think briefly, I would say it's about the ecosystem. It's about the environment, the wider environment. We need to move beyond sort of the one-off research study questions. It's about being intentional, I think. And then the last point, I'd like to see how we can hold ourselves to account to make sure that we are starting to close that research capacity gap.
Thank you. Margaret. Oh, you're on mute.
Oh, sorry. Thank you very much for that. I think at the end of the day, I want to challenge our African governments to stop the rhetoric and support capacity building to help address global health issues that relate to us. Because if we don't take care, other funders will be looking at their own situation and we will still be left in the lurch. So
thank you. Thank you. Very important point. Well made. Marta.
Invest holistically, institutional, national, individual, and for the long term.
Thank you so much. And John.
Well, just to say that the tools for helping us do a better job of being fair in our engagements, particularly around capacity building to do true global health research, do exist. We've heard of more than one of them. I suggest that we take a good look at these and promote them and make them standards to which we hold ourselves accountable. Thank you.
Thank you so much. Thank you to our presenters, to the PhD students, to our panelists, to the many people who worked behind the scenes to make this session happen. And thanks to you all for participating. Our 1 hour is up and we will share the recording when we can. Thank you so much.